Hello, everyone. My name is Dr. Paul Richardson, and I'm the Director of Clinical Research and the Clinical Program Leader at the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston, Massachusetts. I also serve as the R.J. Corman Professor of Medicine at Harvard Medical School. And it's a pleasure to present to you today an update on the very exciting data emerging around the CELMoD class of agents, oral agents that have shown such promise in the treatment of relapsed refractory multiple myeloma, and now in the setting of iberdomide are moving into the upfront space. Very grateful to the Myeloma Hub for inviting me to present to you today. I wanted to start by first of all sharing with you how we must think of CELMoDs, in my opinion, as a distinct class of novel oral agent. They specifically target cereblon as a novel immunomodulatory and protein degrader pathway for the treatment of myeloma. And I want to share with you some preclinical data to help frame that for you. Now, I think what's critical to understand is while there is a relationship to the immunomodulatory class of drugs, they are distinct. Mezigdomide, and which I'll focus on for the moment, binds specifically to the cereblon E3 ligase complex, and by so doing, changes its conformation to recognize different substrates. And as a result of that, there's a highly targeted protein degradation of specific substrate proteins, in this case, Ikaros and Aiolos. And this has a tremendous number of downstream effects. I think what's most important to understand is that in the context of this, the ability of the CELMoD class of drugs to close the cereblon E3 ligase conformation is vital to understanding its potency. Pomalidomide, as probably the most powerful immunomodulatory drug, does so to the tune of about 20%, lenalidomide to about 15%. In contrast, iberdomide closes it to 50% and mezigdomide to a striking 100%. And as mentioned, the result of this is a targeted protein degradation of specific substrate proteins. And so to sort of summarize this for you, and I hope this actually is a little clearer, you can see the immunomodulatory drugs to the left here, really built around the thalamido ring. What's striking about iberdomide is it's based on part of that, but it's a much larger molecule with additional rings as illustrated. And then mezigdomide is even larger in what it does and how it engages the cereblon E3 ligase complex. Now, this results in a whole bundle of differences in terms of pharmacodynamics. As I mentioned, there's this increased binding. Then there's this targeted protein degradation, which is that much more potent for both iberdomide and mezigdomide. And downstream of this, the consequences on tumor antiproliferation are more profound, on tumor apoptosis, immune stimulation in particular, and then profoundly as well, synergistic combinations show greater activity in this context. I think what's a particular important value add to the CELMoD class of drugs is there appears to be a reduced risk of off-target effects on C1k alpha, and this, of course, results in a substantial reduction in the potential risk of second malignancy. And the preclinical data, and this is data from my colleague Adam Sperling, are very encouraging, and clinical observation is ongoing but suggests the same. So to summarize, there's this direct effect on the tumor cell, illustrated to the left here, with this binding of the cereblon E3 ligase complex. And at the same time, there is this consequence in the immune system, which is so dramatic, affecting both NK cells and T cells as well. And we'll talk a little bit more about this in more detail in a moment. And when I focus on mezigdomide, and I'll move through this quickly in the interests of time, the potency of this agent is illustrated here, and these are patient-derived samples to support the point. As you can see here, Aiolos expression in this particular patient at bone marrow examination entering our mezigdomide dexamethasone study is remarkable and intense. It's actually a patient of mine who had unfortunately progressed on isatuximab, pomalidomide, and dexamethasone. Within a week of mezigdomide therapy, as you can see, all of this expression has gone, and this was confirmed more broadly across the trial as well. So this effect is seen in patient-derived samples, so it's clearly an in vivo effect, as well as, of course, a powerful observation in the preclinical setting. Moreover, when you then combine mezigdomide with other backbone agents such as CD38 monoclonal antibodies, steroids, and PIs, synergy is profound and clearly apparent. And then there was some very nice data at this last December's ASH, in which we were able to, or rather the authors were able to show this ability of mezigdomide to overcome cereblon mutations emerging post-IMiD therapy. So to summarize, and this is a particular focus on mezigdomide, I think we can say the following. There are direct immune and anti-tumor effects. There's this synergy. There's a very intriguingly CD38 priming. There's enhanced viability and persistence. in terms of the T cell population. There's this sensitization to T cell mediated killing, which I think is particularly important. Then there's this important effect on CKS1B downregulation, which I think is particularly vital because it suggests there's a potential for activity in a very important area, which is understanding the implications of 1Q amplification in myeloma, and this may be a particularly attractive aspect of it. And at the same time, there's this ability to overcome resistance, which I think is so important. Now, this next slide illustrates how iberdomide binds into the pocket in a much more profound and broad way than does, for example, lenalidomide, and the effects on Ikaros and ALOS degradation accordingly, as well as downstream effects on the immune system. And then, as you see here, the effects of iberdomide and mezigdomide combined with other myeloma therapies has been comprehensively studied, and clear synergy has been demonstrated in a series of elegant studies. So as we think about the overview of immunologic effects, I summarize them here. You can see to the top NK cell activation, which I think is very important. T cell immune stimulation, there's this direct effect, of course, on the myeloma cell itself, with all these downstream effects bring to your attention downregulation of MYC and IRF4, as well as the upregulation of CD38 with increased tumor antigen recognition. So an immunogenic cell death mechanism, I think, is illustrated by this. And then, of course, the profound effects on T cell engagers and CAR T cells, as well as antibody drug conjugates. Now, in terms of immune effects from iberdomide, we can see here increased effector cell abundance, increased activation and decreased exhaustion from patient-derived samples. I think what's particularly interesting with mezigdomide is we see exactly the same, but it's more potent, with increased activation and decreased T cell exhaustion that is clearly apparent. And then there was a very nice paper from our Japanese colleagues showing a whole complexity of effects from CELMoDs on the induction of the, or the reversal, I should say, of the immune suppressive tumor microenvironment by the CELMoD class of drugs.